You're listening to He Said, a Cardiology Board Review Series. No fluff, just facts.
This episode is about key concepts and terms in pacemakers and ICDs. Because dealing with pacemakers and ICDs involves many specialized concepts and terms, I want to take a moment to go over these to make sure that there's no confusion regarding any of the things that were discussed in the prior episodes on device interrogation and device therapies. The material in this episode will not necessarily be directly tested on the cardiology board exam unless you're sitting for the EP board exam, but I feel it is important to know to more meaningfully understand what you're looking at when you're dealing with a pacemaker or ICD. So, in the first section, I'll talk about what are all these two-letter abbreviations you will see on the ICD EGMs. Most of them are going to be sensing events. AS is as atrial sense beat, so the pacemaker ICD is sensing an atrial beat. VP is ventricular pace beat. VS is a ventricular sense beat, and of course, AP is an atrial pace beat. P by itself, a single letter, refers to native atrial depolarization. R by itself is native ventricular depolarization. AR refers to a atrial refractory beat. That's an atrial beat that occurs during the atrial refractory period. VR refers to a ventricular refractory beat. That's a ventricular beat sensed during the ventricular refractory period. PR is the intrinsic P wave to the intrinsic R wave and can be measured on ICDs and pacemakers as well. So I'm talking about these two-letter abbreviations that show up on the EGMs when you look at an ICD strip. You can also have two-letter abbreviations that indicate device therapy, therapy delivery, and detection. So CD stands for charge delivered. It indicates when the capacitor charge has been delivered to terminate a ventricular arrhythmia or attempt to terminate a ventricular arrhythmia. CE refers to charge end, meaning the charge phase is complete and it occurs before the charge is delivered. FD means VFib is detected. F is for fib, FD. Fib detected. TD means VTAC has been detected. T is for tachycardia. So TD is TAC detected. TP refers to anti-tachycardia pacing beat, which means an ATP was delivered. We talk about ATPs in the last episode. RS means reconfirmation started, reconfirmation of the arrhythmia before delivering the shock. SH means shock delivered. EO means end of output, so completion of pacing therapy, the ATP or shock. CP means capacitor charging, so the capacitor has potential for shock delivery. Then we also have two-letter abbreviations that refer to redetection and reconfirmation. RV refers to redetected VFib, which means ventricular fibrillation is being detected again after the initial detection, which would have been labeled as FD, fib detection. RT refers to redetected VTAC, so that means ventricular tachycardia is being redetected again after initial detection, which would have been labeled as TD, TAC detection. NS means non-sustained tachycardia, a self-terminating tachyarrhythmia that does not require therapy. And AR means arrhythmia redetection, can refer to any redetected tachyarrhythmia. Now we'll move on from these two-letter abbreviations on the ICD EGMs to three-letter and four-letter abbreviations, which tend to refer to intervals and timing cycles. AEI is the atrial escape interval, the time from a sense atrial event to the next atrial pace event in single chamber pacing, or from a ventricular event to an atrial pace event in dual chamber systems. AVI is the atrioventricular interval, the time between an atrial sense or atrial pace event and a ventricular pace event. The atrioventricular interval, AVI, is also called AV delay, AVD. SAV stands for sensed atrial to ventricular interval. It's the interval from a sensed atrial event to a paced ventricular event. PAV is paced atrial to ventricular interval. It's the interval from a paced atrial event to a paced ventricular event. The PAV, paced atrial to ventricular interval, is usually programmed to 30 milliseconds longer than the SAV, the sensed atrial to ventricular interval, to allow for conduction of the paced atrial beat to reach the left side of the heart. VA is the ventricular to atrial interval, the time from a ventricular event to an atrial sense or paced event. The VV interval is the time between ventricular beats. It's equivalent to the RR interval on regular EKG. TARP is the total atrial refractory period, TARP. It's the sum of the AV interval and the PVARP, during which no atrial beats can be tracked. And I'll talk about PVARP shortly as well. LRL is the lower rate limit, also known as the base rate or the minimum rate. It is the rate at which the pacemaker paces in the absence of sense intrinsic events. LRI is the lower rate interval and is the sum of the AV and VA intervals. Don't confuse the two. Lower rate limit is the minimum heart rate the pacemaker will maintain in beats per minute, whereas lower rate interval is the corresponding time interval between two consecutive paced beats, expressed in milliseconds. LRI, which is in milliseconds, is 60,000 divided by LRL in beats per minute. For example, a lower rate limit of 60 beats per minute corresponds to a lower rate interval of 1,000 milliseconds, which is 1 second. Pacing interval is the time between two consecutive paced events. Now, let's talk about the 3 to 5 letter abbreviations that refer to refractory and blanking periods. ARP, the atrial refractory period, is the period after an atrial sense or atrial paced event when the atrial sense amplifier is unresponsive. VRP or ventricular refractory period is the period following a ventricular event during which the sense amplifier is unresponsive but sense events are counted. Blanking period is a short interval when the sense amplifiers are temporarily disabled to prevent inappropriate detection. For example, crosstalk prevention. PVAB, the post-ventricular atrial blanking period, is the blanking period after a ventricular event to prevent sensing of the ventricular event by the atrial channel. PAVB, the post-atrial ventricular blanking period, is the initial part of the ventricular safety pacing window where the ventricle is blind to signals. PVARP, or PVARP, post-ventricular atrial refractory period, is the period after the ventricular beat designated as a refractory period to avoid tracking of retrograde P waves, or PACs, in order to avoid pacemaker-mediated tachycardia. So PVARP is very important for avoiding PMT. Any atrial beat falling into the PVARP is labeled as AR, A refractory, and is not used to initiate an AV interval. Relative refractory period is the period following the absolute refractory period where the device may sense signals but does not reset the timing circuits. TARP, or TARP, is the total atrial refractory period. The maximal rate that a dual chamber pacemaker can sense is determined by the total atrial refractory period, which is composed of the AV interval and the post-ventricular atrial refractory period. If an atrial beat falls into this TARP interval, it is called AR. The PVARP is an interval during which the atrial channel can see incoming signals but will not respond to them. However, because signals are seen in PVARP, the pacer can assess whether high atrial rates are occurring. As the sinus rate increases, the native atrial intervals become shorter than the TARP, and some atrial events will not be sensed. An abrupt fixed block occurs as the pacemaker only intermittently senses the P waves, which may result in symptoms as the rate drops precipitously. When the atrial rate reaches the TARP rate, the pacemaker may exhibit 2-to-1 block behavior. TARP is SAV plus PVARP, and the TARP rate in beats per minute is 60,000 milliseconds divided by TARP in milliseconds. That is the refractory and blanking periods. Now we'll go over the safety detection windows and margins. VSP is the ventricular safety pacing window. After an atrial paced event, this window, the VSP, allows any ventricular event sensed during this time to trigger a ventricular pacing output. This is designed to prevent crosstalk inhibition and ventricular capture during the vulnerable period after an event, atrial event. Atrial sensed events do not initiate a VSP interval. Only atrial pace events initiate a VSP interval. CDW is a crosstalk detection window. In dual chamber pacing, the period following the ventricular blanking where ventricular sensing is considered crosstalk but results in safety pacing. How about safety margins? Safety margins can be applied to voltage or to pulse width. The voltage output should be programmed to a level that is approximately twice the capture or stimulation threshold for a 2-to-1 output safety margin. The pulse duration should be programmed to a level approximately 3 times the pulse width capture threshold for a 3-to-1 output safety margin. The typical range for pulse width is 0.2 milliseconds to 1.0 milliseconds. Now we'll talk about pacing modes and switching. AV, or atrioventricular sequential pacing, is one of the dual chamber pacing modes. For further details on the different pacing modes, look at the last episode where I talk in detail about the different kinds of pacing modes for each device. But I want to go over some special terms and concepts here. MVP is managed ventricular pacing, a feature that will minimize unnecessary right ventricular pacing in patients who have intrinsic atrioventricular conduction by using intrinsic atrioventricular conduction when it is present. Prolonged ventricular pacing is bad because it causes ventricular dyssynchrony, causing LV remodeling, reduced EF, pacemaker-induced cardiomyopathy, and death in patients who already have a reduced EF. With managed ventricular pacing, the device alternates between atrial-based pacing, such as AAI, when intrinsic conduction is present, which minimizes side effects from unnecessary prolonged RV pacing, and dual chamber pacing, such as DDD, which provides safety in the event of AV block and only does DDD when necessary. In other words, it will at baseline do atrial pacing. When it senses AV block, it can then mode switch into DDD. Now, what about mode switch? Mode switch is a marker that activates when the atrial rate exceeds the program limit, switching the pacemaker to a non-tracking mode. When a rapid atrial rhythm is detected, such as AFib, aflutter, ATAC, or paroxysmal SVT, the device can switch from an atrial tracking mode, such as DDD or DDDR, to a non-atrial tracking mode, such as DDI or VVI, to prevent the pacemaker from tracking and inappropriately pacing the ventricles at the high atrial rate during these episodes of supraventricular tachycardia. There are a few special pacing features. One is rate adaptive pacing. You have automatic adjustment of the pacing rate based on activity levels, such as exercise or stress, using motion sensors, such as accelerometers, impedance sensors, or minute ventilation sensors, to ensure the heart rate is appropriate for the patient's activity level and improving exercise tolerance and quality of life in patients who cannot increase their heart rate naturally. That's chronotropic incompetence. When you see that fourth letter, R, such as in AAIR, VVIR, DDDR, the pacemaker will increase the pacing rate in response to physical activity, such as when you go from sitting, sleeping, to walking, to running, if the patient does not already increase his or her own heart rate. RAAV, the rate adaptive AV interval, is an option to make the pacemaker's AV interval decrease as the patient's heart rate increases. This parameter can help with managing upper rate behavior. RRAVD is the rate responsive AV delay. It shortens the AV interval as the atrial rate increases to accommodate higher heart rates. This is designed to provide a more physiologic AV interval at higher heart rates and to allow for tracking of higher atrial rates. A shorter AV interval decreases the TARP, thereby lessening the chance of a fixed block upper rate response. Hysteresis is a pacing feature that attempts to allow the heart's native conduction system to predominate and therefore modifies the base rate behavior. The feature works by using a longer escape interval after a sensed beat than a paced beat. For example, the device can set the hysteresis rate at 50 beats per minute, whereas the base rate stays at 60 beats per minute. Therefore, if the patient's intrinsic rate is more than 50 beats per minute, the device will not pace. But if the patient's rate falls below 50 beats per minute, then the pacer will kick in and pace at 60 beats per minute instead of 50 beats per minute. As hysteresis can appear as an unusually long delay on the ECG strip, it can be mistakenly interpreted as failure to pace or inappropriate sensing. Sleep function. You can actually set a sleep rate in a lot of these devices as well. At a predefined bedtime, the device will gradually reduce the operating pacing rate from the lower rate to the sleep rate and keeps it there until the predefined wake time. Now, a few important concepts of tachycardia management. Pacemaker-mediated tachycardia, or PMT, is inappropriately rapid pacing caused by the pacemaker sensing and tracking retrograde P waves. The solution to that is to use the post-ventricular atrial refractory period, or PVARP, or if it's already set, then extend the PVARP by 50 milliseconds beyond the VA interval to avoid tracking retrograde P waves, or PACs. The upper tracking rate, or UTR, is the maximum rate at which the pacemaker can track atrial events with ventricular pacing. If the atrial rate gets to be above the upper tracking rate and below the TARP rate, there will be pacemaker-induced Wenckebach. Typically, you set the upper tracking rate as 0.85 times the brackets of 220 minus age, expressed in beats per minute. Replacement indicators. Recommended replacement time, RRT, or elective replacement interval, ERI, indicates that the pacemaker or ICD battery is nearing depletion, typically with 3 to 6 months of function remaining. End of life, or EOL, is depletion of the device battery, often indicated by changes in pacing rate or mode. Now let's talk about the lead system components. Anode is the positive electrode of the pacing lead. It's proximal in bipolar systems and pulse generator case in unipolar systems. Cathode is the negative electrode of the pacing lead. It's distal in both unipolar and bipolar systems. The terminal pin is the male portion of the proximal lead that connects to the pulse generator. The lead body consists of conductors and insulation. The conducting wire connects the stimulating and sensing electrodes to the terminal pin. The lead insulation is most commonly silicone rubber or a polyurethane material. Stimulating or sensing electrodes are the distal end of the lead that connects to the atrial or ventricular myocardium. Fixation devices. Passive fixation is when an attachment mechanism, such as fins, anchors electrodes to the endocardial trabeculae. Active fixation, which is now the standard, is when the leads are secured in the endocardium using a screw-in mechanism. Active fixation has a lower rate of the early dislodgement and higher chronic capture thresholds than passive fixation. Now let's go over diagnostic and performance terms. Capture, that refers to effective cardiac depolarization following a pacing stimulus. Non-capture refers to failure of the pacing stimulus to depolarize the cardiac tissue. Impedance, referred to as the letter Z, is resistance to electric current measured through the pacing lead and surrounding tissue. There should be a decreasing impedance over the first 1 to 2 weeks following implantation of the device, then an increase to a level that is somewhat higher than impedance at the time of implantation. Sensing is the ability of the pacemaker to detect intrinsic cardiac signals determined by the amplitude threshold required. Oversensing is detection of inappropriate signals such as extracardiac signals or T waves leading to underpacing. Undersensing is failure to detect intrinsic cardiac signals leading to overpacing. Some other miscellaneous terms. Crosstalk is inappropriate sensing of an event in one chamber by the opposite chamber's sense amplifier. External EMI is electromagnetic interference that may affect pacemaker function. Magnet mode is a mode triggered by applying a magnet over the pacemaker, typically switching to asynchronous pacing. Reed switch is a switch in the pulse generator that closes when exposed to a magnetic field, thus enabling magnet mode. Fusion is a beat that results from intrinsic depolarization and pacemaker output occurring simultaneously. Pseudofusion is a beat where pacemaker output is delivered but does not contribute to depolarization because intrinsic activation occurs first. That's all I have for you for key terms and concepts in pacemakers and ICDs.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.